Hello dear guys, today we're going to discuss the benign prostate hyperplasia. I hope you heard about this condition, I hope you know about this condition something, but today we'll discuss it in much more details. First we should talk about abbreviations we will use in this lecture. I'll try to discuss it. BPH, it's a benign prostatic hyperplasia. LUTS, it's a lower urinary tract symptoms. BOO, it's a bladder outlet obstruction. BPO, it's a benign prostatic obstruction. OAB, it's overactive bladder. BPE is benign prostatic enlargement. AR, androgen receptor. HRQOL, health related quality of life. And IPSS, International Prostate Symptom Score. Differences in these terms we're gonna discuss in a further topic. So, benign prostatic hyperplasia, it's a pathologic process that is one but certainly not the only cause of lower urinary tract symptoms in aging men, also described as male LUTS. So, point is that benign prostatic hyperplasia happens in every person, every male person who had a normal history of hormonal production. So if you had normal hormonal production during your aging process, so then you will have benign prostatic hyperplasia. But but not every benign prostatic hyperplasia will cause the LUTS, so lower urinary tract symptoms. They are present in a lot of patients, but not in all patients. So we'll discuss it in further description. Failure to empty can be related either to an outlet obstruction or to detrusor in underactivity of the bladder or to a combination of both. So you see, prostatic hyperplasia, so obviously it causes obstruction. Obviously it restricts the passage of urine through the urethra in prostatic urethra, and it can cause failure of empty. But point is that in females during the aging, they also have similar symptoms in less common amount, but detrusor underactivity. So it might be present not only in males but in females too, and it has a very great impact in this disorder too. So that's why we are talking about combination of both, and must the anatomical changes are also followed with physiological changes in the detrusor. Many men older than 40 years of age will develop histologic hyperplasia, but not all will have bothersome LUTS. So, as I said in the beginning, prostate enlargement is not always related with lower urinary tract symptoms, and there are a lot of males who has a very enlarged prostate, but they don't have any type of lower urinary tract symptoms. So which lower urinary tract symptoms you should know? So it's irritation, it's emergency of urination, it's dissatisfaction with the urination, storage symptoms are currently largely encompassed by the term of overactive bladder. So when patient can't keep a lot of urine, so then even a little distension of urinary bladder will cause the desire of urination, then desire of pee, which symptoms includes urgency, frequency, and nocturia, and urgency incontinence sometimes. So you see, it's nocturia. It's a night urination. So when you go to the toilet at night, sometimes few times. Urgency incontinence. It means incontinence is failure to keep the urine, but we have non-urgent incontinence when a patient go to toilet, or just when extraction of urine happening. Voiding happens, but patient doesn't feel it, and after the voiding, he just realized it. He just pissed out. And urgency incontinence is when patient feels it. The patient wants to go to toilet, but he has no time to reach the toilet, and this is this symptom of overactive bladder, and It is believed to be correlated with underlying detrusor overactivity. And these symptoms are related not only with benign prostatic hyperplasia, but it usually correlates with the symptoms of Lutz and prostatic hyperplasia too. So that's why it's not so simple. Yeah, I can explain it in simple way, so that it's just enlargement of prostate which causes irritation. But another hand, we should keep it in mind that prostatic hyperplasia is not only the reason of this condition. And here let's talk about incidence of it. All men elder than 40 years old, almost in all males of elder than 40 years old, we have histologic benign prostatic hyperplasia. So it might have no clinical evidences, might have no any kind of signs that require the treatment. And during the aging, histologic BPH reaches 100% as elder this number is, so it's 60, 70, 80 years old. Almost every male will have this histologic benign prostatic hyperplasia, but it's not correlated with other symptoms like Lutz, lower urinary tract symptoms, so BOO, so bladder outlet obstruction. So you see it happens only low incidence, and sometimes even is not related with histologic BPH, you see. And also have enlargement, benign prostate enlargement. So it's okay, we'll discuss it how it looks like. So, and this diagram, so it's relatively explains the symptoms, relatively explains the incidence of this condition. Little talk about anatomy of this condition. So this is normal prostate of a young male. Yeah, so you see it has central zone, it has transitional zone, it has anterior fibromuscular stroma, it has urethral part, so it's a corpora cavernosa is started here, yeah, and yeah, peripheral zone I said, yeah, I guess. So where and periurethral stroma, yeah, periurethral stroma, we discussed it in prostatitis, yeah. So this periurethral stroma is suffered first in this condition, because usually followed with urethritis and all infection is which is coming here. First of all bothers this periurethral stroma, and we have calcification of the stroma and so on. But here we have transitional zone. Transitional zone is a part which usually affected by hyperplasia, and you see this is elder patient, elder male, so who has enlargement of this median lobe, and the enlargement of the transitional zone, which forms the median lobe too. So about the process of this growing, so we'll discuss a little later. So it has very complicated pathophysiology, and a lot of etiologic factors are not well known, but in a very large, so like here shown, so predominancy of patients are suffering with benign prostate hyperplasia. They have this benign prostate hyperplasia, especially of this peripheral transitional zone. Okay, etiology. So now let's talk about etiology. Histopathologically characterized by increased number of epithelial and stromal cells. Again, number of epithelial stromal cells. That's why it's hyperplasia but not hypertrophy. So here you should feel the difference. Yeah, in pathology we discussed. Yeah, that hyperplasia is enlargement of organ due to increasing of number of cells, and hypertrophy is when all cells are enlarged. So that's that should be noted. In older literature, they claim this hypertrophy. So, and this is main point of the discussion. The precise molecular etiology of this hyperplastic process is uncertain. So we don't know. So what is the reason of it? Androgens do not cause BPH. The development of BPH requires the presence of testicular androgens during prostate development, puberty, and aging. So we don't have correlation between level of androgens and growth of this of this prostate. But males who had no sex hormones, who had no so for example after castration, yeah, so in childhood, so they don't have benign prostate hyperplasia, and during the aging process, so if the level of testosterone is lower than normally, so then prostate hyperplasia does not reach. But it doesn't work in elder period. So if this process already started, so it will continue even if, unrelated to the level of testosterone. The prostate, in the prostate, the nuclear membrane-bound enzyme steroid 5-alpha reductase converts the hormone testosterone into DHT, the principal androgen in this tissue. So, and it is believed that level of DHT, dihydrotestosterone, which converts 5-alpha reductase, it converts testosterone into dihydrotestosterone. So, which playing the trophic role for the epithelial and smooth muscular cells in the prostate. And it is believed that blockage of this 5-alpha reductase enzyme causing the decreasing of progression of benign prostate hyperplasia. But so in my practice and actually international literature about this, they can't confirm it. So because in some patients they feel that prostate enlargement is not so high, and the symptoms are not so severe. Yeah, so when they use 5-alpha reductase inhibitors. But in general population, it works as a placebo effect. So a similar placebo effect might be a little bit better, but we don't have a treatment and we don't have prevention of this benign prostatic hyperplasia. So etiology also affects androgen receptors. So some subtypes of androgen receptors they increase the risk of this benign prostatic hyperplasia. But as you know, every person they have benign prostatic hyperplasia. Almost every person. So and that's why we can't claim that it's androgen receptors playing a very significant role. Might be in the patient with a specific androgen receptors, we have much more rapid type of development of this prostatitis, of benign prostatic hyperplasia. Then dihydrotestosterone and steroid 5-alpha reductase, we already discussed it right now. Estrogens, so that it was believed that estrogens level elevation, so it will cause also hyperplasia, but it's not confirmed. But some role is involved here. Regulation of programmed cell death. Okay, this is a central role in the formation of benign prostatic hyperplasia. You remember that, so you can understand it, yeah. So if we have cell division, so if cell division is continued, so of course we have to kill some cells which are too numerous here, and failure of programmed cell death. So when cells divided but still remain in this tissue, so it will cause the hyperplasia. It's the definition of hyperplasia. And obviously somehow the programmed cell death regulation is failed, and the population of cells of transitional zone of prostate is grown. Stromal epithelial interaction, of course, so epithelial cell growth is followed with the growth of stromal cells, and these growth factors which are present here, so we can talk about it together. Now they stimulate the growth of not only of one type of cells, but also all the types of cells. Inflammatory pathways and cytokines in benign prostatic hyperplasia. Previously, it was believed that patients who had chronic prostatitis, patients who had infections, sexually transmitted infections, STDs. So they have much more higher incidence of this benign prostatic hyperplasia. But a lot of research after it, so realize that it has no any actual role. Yeah, it is believed that cytokines which stimulate the prostate always so like in process of healing, So it causes the proliferation of the cells, proliferation of cells of stroma, and proliferation of cells of muscular cells, smooth muscle cells, and of course epithelial cells. But it's not confirmed yet. And of course genetic and familial factors. Genetic and familial factors, they are really playing very important role. So that if your father had a benign prostatic hyperplasia in age of 45, for example, which is very early, so it is believed that you will have similar. It's might be related to specific type of androgen receptors, so genetics of androgen receptors, because it's protein. Type of 5-alpha reductase, so which overactive with aging. So might be also estrogens and regulation, failure in regulation of programmed cell death during the aging. So it's also predisposed by genetic factors. So some genes which fail the normal programmed cell death in this organ. That's it. Very direct relation. Pathophysiology. Oh yeah, but wait, but we have no one evidential reason of this benign prostatic hyperplasia on which we can act on which, so we can prevent the benign prostatic hyperplasia. We don't have prophylaxis of this disorder. Prophylaxis is absent, so that's I wanna point at it. So no prophylaxis of benign prostatic hyperplasia. Yeah, of course, it's better to avoid inflammation in prostate. Of course, it's better to keep the normal level of androgens, keep the normal level of estrogens also. Of course, if you have good regulation program cell death, so you have lower incidence of cancer. But anyway, so that in the majority of population, so we'll have benign prostatic hyperplasia. Pathophysiology. So if we have a fact of benign prostatic hyperplasia, so it increases urethral resistance. So urethral resistance, so it's not collapsing properly because masses are present there, and we have compensatory changes in bladder function. So which compensatory changes in bladder function you should realize? So that in initial stages of benign prostatic hyperplasia, you voiding properly, but you have to force more tangent for urination. You don't even mention it. So, but when you go to toilet, so your smooth muscles of urinary bladder contracting more severely, and of course, if you have and here smooth muscles working like hypertrophy. Yeah, so we have hypertrophy of smooth muscle cells of urinary bladder. And if we see the cystoscopy, so when we observe the urinary bladder with the camera, we see the trabeculation. Trabeculation, so which means it's like your biceps when you go to gym. Yeah, so trabeculation is when urinary bladder is trained. So it shouldn't be trained. Yeah, but if it's trained, so you can see it. Oh, must be you have a load. You have a very high load to this urinary bladder. So, and obstruction-induced changes in the detrusor function compounded by age-related changes in both bladder and nervous system function lead to urinary frequency, urgency, and nocturia as the most bothersome BPH-related complaints. LUTS, yeah, so lower urinary tract symptoms which are explained here. This is also congestion. Yeah, so but physiologically it's a congestion. Congestion of urine in the urinary bladder, and of course it causing the detrusor function changes. Yeah, and of course due to congestion here, so venous flow also, venous backflow from the urinary bladder is also failed, and one of the mortal complication of benign prostatic hyperplasia, it's urinary bleeding. So when varicosely changed urinary bladder veins, they are ruptured, and bleeding comes to the urinary bladder in a rapid way. It's a rare condition, but it is one of the causes of mortality during this condition. So here a little bit about pathophysiology. Prostate hyperplasia, it causes bladder outlet obstruction, non-BPH causes of obstruction. Might also causes bladder outlet obstruction. Okay, detrusor response. It's detrusor aging effects, which we discussed before. Neurogenic disease. which might also cause effect here. So, for example, a lack of normal neurostimulation of this detrusor. And primary bladder disease might be chronic cystitis or tumor or polyps or anything else. Might be congenital conditions. Yeah, so when congenitally changed urinary bladder. And finally we have LUTS, yeah, so this lower urinary tract symptoms, and these symptoms should not be confused with polyuria. So when more urea is produced, so of course you have also high frequency and urgency also, so because it's normal work of a urinary bladder, and urgency increases. But polyuria, so along with these conditions, will cause the lower urinary tract symptoms. So that you should exclude these points and treat these points first to treat the benign prostatic hyperplasia. So that's why just surgical removal of benign prostatic hyperplasia is not an option. Is not the only option. So this you also have to keep in mind. Anatomic features. So BPH first develops in the periurethral transition zone of the prostate, as I said in the beginning. Transition zone is here normally, and here we have verimontanum. Verimontanum is a hallmark for the presence of ejaculatory ducts. So here we see ejaculatory ducts, and of course, so this hallmark is very important during the surgery we perform in the benign prostatic hyperplasia. We can't cut we can't make an incision below this, below and on this verimontanum. So that's why we just cut here, 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 but never this. So that's why, and we shouldn't destroy the peripheral zone. So peripheral zone is usually not affected by benign prostatic hyperplasia. So we have to point the role of prostatic capsule. So that's only unique feature of human prostates, the presence of the prostatic capsule, which plays an important role in the development of LUTS. So you see, if growth happening, if prostatic capsule is tensible or it's absent, so that's the prostate growth can be directed not only in the restriction of urethra, but it can grow anywhere else, yeah, in peripheral part, so where we have placed. But due to presence of capsule, it grows towards the urethra and obstructs the urethra. And clinically, so doctors of previous years, they just had a lot of experiments. Yeah, as I said, so historically doctors are very initiative, yeah, and they like experiments, and they just made experiments. They documented that the incision of prostatic capsule sometimes result in significant improvement of outflow. So then if we allow the nodule to grow in other direction, so then outflow is remain normal. So then but volume of prostate remains the same, but its growth, it had opportunity to grow in other direction, so and then outflow is a return. The outflow is normal. Again, the size of the prostate does not correlate with the degree of obstruction. That must be pointed, that size of prostate is not prescription for surgery. Size of prostate has no clinical sense. So everything which has a sense is complaints. Are the complaints. So in some cases, predominant growth of periurethral nodules at the bladder neck is rise to the middle lobe, and yeah, I can show it here. Middle lobe or median lobe. So when it's which growing into the urinary bladder, which grows in the urinary bladder and causing these irritation symptoms. So the middle lobe must be of periurethral origin, because there is no transition zone tissue in this area. It is not clear whether middle lobe growth occurs at random in men with BPH, or whether there is an underlying genetic susceptibility to this pattern of enlargement. specific pattern, but with this middle lobe we have much more irritative symptoms and much more symptoms of lower urinary tract symptoms. So that's why we should you should so size of this middle lobe, so it is correlate with the symptoms. So and here, yeah, here is the middle lobe. So you see, it's absolutely normal prostate, but it has middle lobe, which protrude into the urethra, in urinary bladder. Here again, middle lobe. So growth of gross prostate is happening, but no middle lobe, and usually this doesn't give symptom. Here we have growth of so similar growth here, but along with middle lobe. So there we see the symptoms of loops. And here, so also it's one lobe is protruded, but without formation of middle lobe pattern. Prostatic smooth muscle represents a significant volume of the gland. So you remember that the prostatic gland is a it's as well it has endocrine and exocrine function. It is a muscular organ too. It's playing a role in urination, of course, and also playing a role in ejaculation, and plays a role in erection too. So that's why smooth muscles are present a lot. So, and it was discussable which component is more important in this. So previously it was thought that epithelial tissue, which is present, glandular tissue, which is present in the prostate, so playing a very important role. So and the connective tissue playing an important role. So which is more dominant? It was a question, but it has no questions that prostatic smooth muscle playing very important role. Active smooth muscle tone is in the human prostate is regulated by the adrenergic nervous system, and we have adrenergic receptor, which adrenaline receptor, alpha 1 adrenal receptors in the prostate, and actually use of alpha receptor blockers, so which is tamsulazine, tamsol, or omnic. So this preparations, these compounds, they cause the blockage of these alpha receptors, and they diminish this response. So it's playing a role in treatment. Bladder's response to obstruction. First, the changes that lead to detrusor instability or decreased compliance are clinically associated with symptoms of frequency and urgency. And second, the changes associated with decreased detrusor contractility are associated with further deterioration in the force of the urinary stream, hesitancy and intermittency, increased residual urine, and in minority of cases, detrusor failure. So, based on this description, so we have our old Russian Soviet Union classification of prostate hyperplasia. So, and we classify it into three terms. So, first stage, second stage, and third stage. So, first stage is when we see only lower urinary tract symptoms, the only lower urinary tract symptoms. In second phase, we have a residual urine. So this is the main feature, main point of this secondary benign prostate hyperplasia. When we have retention of urine in the bladder, so it's a symptom that it might cause a complication later, and it's a direct prescription for surgery. So if in first stage, so when we just have irritation symptoms, we can help it with alpha blockers. We just prescribe alpha blockers chronically, and patient feel much better. But in second stage, so it's very prescribed the surgical treatment. Surgical treatment is the best option. And third stage of hyperplasia is related with complications. If we have any kind of complications of prostate, so then about complication we'll discuss a little later. But the severe complication usually does not, they don't allow the proper surgery coverage about this patient. So that's why surgically we treat, surgically by removing of prostatectomia we perform, or adenomectomia, We perform only in case of second stage of prostate enlargement. In third stage, we have some additional types of surgeries. So, okay, we'll discuss later. Increase in muscle mass, also an adaptive response to increase in intravesicular pressure and maintain flow is associated with significant intracellular and extracellular changes in the smooth muscle cell, as it lead to detrusor instability and in some cases impaired contractility. Correlations, yeah. So all parameters such as symptom severity and frequency, border interference, this specific HRQOL. So it's quality of life, yeah. Maximum flow rate and prostate volume tend to worsen with advancing age. So only age is a factor for the progression of the disease. Reported correlations between these parameters and urodynamic pressure flow studies are in general weak with some exceptions. Strong correlation exists as one might expect between subjective measures such as symptoms, severity and frequency. It's measured by IPSS, International Prostate Specific. So it's like MCQ for symptoms of irritation of urinary bladder. Border, disease-specific HRQOL, and interference scores. Complications of benign prostatic hyperplasia. Mortality. So mortality. So in 1950s. 1954, it was greater than 10 per 100,000. So yeah, and why I'm talking about this time, 1950 and 1954. So when we had no proper help, yeah, we had no proper surgeries, we had no proper techniques to treat this disorder. And mortality was pretty high, so due to complications of benign prostatic hyperplasia. And but now this mortality is insufficient, and usually if we have death during the surgery or after the surgery, it's related to comorbidity, so other disorder underlying this condition. So and in good clinics like Dock University Clinic is, so mortality rate is 0.0, yeah. So we don't have death due to benign prostatic hyperplasia. And everywhere, so in every country which has at least normal healthcare system, no one dies because of benign prostatic hyperplasia if they admit to hospital. And usually they admit to hospital. Bladder stones. So bladder stones are predominantly 8 times higher frequency of these bladder stones in patients with benign prostatic hyperplasia, and in controls is just 0.4% of population, and usually it's related to other disorders like neurogenic urinary bladder. So for formation of bladder stones, we require first it's a caliculi stone, so a caliculi formation in the kidneys, and then this caliculi, then the stone is just remained in the urinary bladder for a long time. So and it is possible when voiding is not complete. So when voiding is not complete, stones remained, and then new salts are adjusted and attached to the surface of this previously formed stone, and size of the stone enlarges. So and it's possible only in second stage of benign prostatic hyperplasia and other disorders which causes the voiding problems. Primarily, these bladder stones are never found just with the fully good condition. Bladder decompensation. Biopsies from tuberculated obstructed bladder show dense connective tissue deposition, a finding similar to that seen in experimentally obstructed animals. So a bladder fibrosis in both sexes with advancing age and may be a normal consequence of aging. So, and of course, if you have a benign prostatic hyperplasia, tuberculation is much more severe. But as well, it's present in both males and females, so must be just aging consequence. Complications of benign prostatic hyperplasia continue. It's urinary incontinence. Urinary incontinence. So you see, if we have detrusor instability and detrusor overactivity, so of course Incontinence might present urgent incontinence, and also even so due to decompensation of this detrusor muscle, it can cause the it causes urinary incontinence. So when patient doesn't even feel that he go to toilet, and usually with urinary incontinence is correlated with hydronephrosis. So we discussed it in topic of hydronephrosis that hydronephrosis in males might be present due to obstruction of urinary pathways of lower urinary tract, and when you have decompensation of urinary bladder with formation of incontinence, or with the formation of a paradoxical ischuria. So when patient wants to go to toilet and he can't go to toilet, but when he just walking around, so then he has leakage, voiding happens. So that's very irritateful, and usually in this condition patient already has the hydronephrosis. Of course, kidneys also, it leads to kidney failure in long term. Urinary tract infections. So, of course, if we have congestion of urinary bladder, of course, it causes the infections too. Then upper urinary tract deterioration, azotemia. That's what I said. Yeah. So when urinary tract deterioration happens, it's a hydronephrosis, and due to hydronephrosis, it evolves the kidney failure, chronic kidney failure, and of course, it leads to azotemia. Hematuria. Hematuria, as I said, yeah, that during the chronic exposure of prostate, during chronic exposure of pressure in the urinary bladder, so it leads to formation of varicosely changed veins of bladder, and sometimes during making some procedures or just spontaneously, these veins can be ruptured and leads to hematuria, blood in urine, so a massive hematuria, and it sometimes really causes the death. So, and I had only one case of death in my practice, so which was related to hematuria actually. And when patient just came to us with the fourth stage of benign prostate hyperplasia, and he just get to the hospital, and at morning he died. Due to profound bleeding, and we had no time to send him to emergency or even. Okay, and acute urinary retention. So that's most overused diagnosis. Yeah. So I can explain it. So in our hospitals, we have a prescription for urgent help. So in our central hospital of urological help, so we have two directions. Yeah. So one is through the polyclinic. So you have to visit doctors, and one doctor, and this doctor give it the direction to the hospital for the treatment, and he required to examine you totally, yeah, so before the surgery, and then he sent you to the hospital only. It's an official way, so how it should be there. But a lot of patients, they are not coming to polyclinics, and they directly go to the doctor in a center, in a hospital, and in a hospital, so they don't want to send this patient to polyclinic. Yeah. So what's the reason? But by rules they have to go there, and that's why in fake way, so they write acute urinary retention. So that's and it's a urgent case, of course, and with this urgent case, so they can examine this patient directly in a hospital without outpatient help. So that's this diagnosis is overused in Kyrgyzstan, but it's pretty rare complication of benign prostate hyperplasia. And etiology is poorly understood. It might be obstructive, myogenic, neurogenic causes. In my practice, so when I had acute urinary retention, it usually followed with alcohol use. So when the patient already had the benign prostate hyperplasia, but after the use of alcohol, so somehow prostate is enlarged, or might be infection, so gets more severe. Bladder over distension happens due to chronic distension of the urinary bladder. here we're written alcohol consumption, but I should be in the first place. Sexual activity, debility, better rest. So, and might be related to prostatic infarction. So when prostate is too large and due to alcohol use or due to vascular reasons, so some part of this benign prostate hyperplasia dies, and as well it's dying, so as well it's destroying, so it may cause acute urinary retention. So, and stages. And here we should talk about staging. Yeah, so staging of as I said, so I was studied to another staging type. So it's stage 1, stage 2, stage 3. And as I said, staging is different in Western countries and post-Soviet Union countries. Is stage 1. Those with no bothersome symptoms and no significant obstructions, they can generally be watched. So it's just sometimes we perform ultrasonography and we realize that they have hyperplasia. So like every person older than 40 years. Yeah, and this is claimed as stage 1. Stage 2, those with bothersome symptoms but without significant obstructions, they can be treated with pharmacotherapy, thermotherapy. So thermotherapy is useless, but pharmacotherapy with alpha blockers. Stage 3 is those with significant obstruction, defined as a uroflow of less than 10 ml per second. It's a uroflow meter is used for this test, with persistent residual urine of more than 100 milliliters. So in Soviet Union we use 50 milliliters, but here 100 milliliters. And transurethral prostatic resection is recommended, or transurethral enucleation of prostate is an even better option. In stage 4, those with complications of BPH such as chronic retention of urine and bladder stone, they will need transurethral resection of prostate. But in post-Soviet countries, last stage is when you have a retention of residual urine, which is very large, and presence of complications in kidneys, especially when you have hydronephrosis, or if we have the if we have paradoxical ischemia, or kidney failure is evolved. So this is stage number 3. So okay, thank you for attention. See you next time. Goodbye.